Welcome to the Explainer. Today, we're untangling the surprisingly complex web of central venous access billing codes. If you've ever stared at an operative report, scanning through endless lines of surgical jargon, and felt, entirely lost in the terminology, you are absolutely in the right place. Let's get into it. Here's our quick roadmap for today. What is a central line? Key factors for accurate coding, the port terminology trap, coding non-tunneled and tunneled lines, devices with ports and pumps, and finally, complex access and two catheters. Basically, we're going to build a foolproof decision tree to totally lower your cognitive load.
All right, Section 1. What is a central line?
Okay, so to accurately code any procedure, we first got to establish our baseline definition, which is a strict anatomical requirement. To actually be considered a central venous catheter, or CVC, the catheter tip absolutely must terminate in one of these very specific locations. We're talking the right atrium of the heart, the superior or inferior vena cava, the subclavian vein, the brachiocephalic, also known as the innominate vein, or the iliac vein. If that catheter tip doesn't reach one of those exact anatomical spots, no way around it. You cannot code it as a standard CVC.
But what happens when a procedure doesn't go exactly as planned? Let's say a CVC placement is started, but the physician just cannot maneuver the catheter into a central vein, and the tip is left in a non-central location, like the axillary or cephalic vein. Well, that creates a midline catheter. I want to immediately draw a boundary here. Midline catheters require completely different codes, specifically 36400, 36406, or 36410. They have their own specific rules, and they are definitely not our focus for today's explainer.
Moving right along to Section 2, Key Factors for Accurate Coding.
Once you've confirmed a true CVC was placed, your job kind of transforms. You're a medical detective now. You need to filter the operative report for a few critical variables that will drive your code selection. Was the insertion site peripheral, making it a PICC line, or central, making it a CICC? What about the patient's age? Are they under 5 years old or 5 and older? Did the surgeon attach an implantable port or maybe a pump? You also need to verify the pathway. Was it placed directly through the skin into the vein, meaning non-tunneled, or was it tunneled through the soft tissues away from the entry vein? And finally, what's the procedure type? Initial placement, an exchange, or a repair? Every single one of these variables is absolutely crucial.
Next up, Section 3, the port terminology trap. Consider this an urgent pro tip, because honestly, this is where a lot of painful coding errors happen. We have a major terminology clash between the operating room and the coding manuals. The coder's definition of a port is absolute. It is a reservoir totally implanted under the skin. Access is gained by inserting a needle right through the skin into that reservoir, and absolutely no part of the catheter or port is left outside the body. Physicians, on the other hand, they'll frequently use the term port completely casually for the ends of a central venous catheter that remain outside the body. You might see them document terms like a blue port, a red port, a cap, or a hub. Because of that massive clash, here is your golden rule. When in doubt, clarify. You must never, ever assign a code for a catheter with an implanted port simply because the word port popped up somewhere in the surgical report. If the documentation leaves you even slightly unsure about whether an actual subcutaneous implanted port reservoir was placed, you absolutely must clarify with the physician before you finalize that code. All right, Section 4, Coding Non-Tunneled and Tunneled Lines.
Let's crack open the codebook and start building out our deductive decision tree, starting with non-tunneled, centrally inserted codes. It's actually pretty straightforward. If your patient is younger than 5 years of age, you assign code 36555. If they're age 5 or older, it's 36556. These two codes apply when a catheter is inserted directly into the jugular, subclavian, femoral, or inferior vena cava. The big distinguishing factor here? A subcutaneous tunnel is not created, and there's no implanted port or pump. It's just a direct, non-tunneled line.
Now watch how our decision tree branches when the surgeon changes their approach. For tunneled, centrally inserted codes without a port or pump, we shift over to a completely new pair of codes. For patients younger than 5, you're going to use code 36557. For those 5 or older, it's code 36558. This shift happens when the physician inserts the catheter into a vein, but then routes or tunnels the part of the line outside the vein under the skin, right through the soft tissues, bringing the end of the catheter out through a small incision away from the original entry point. So, we've successfully mapped out simple, direct lines and tunneled lines. Pretty good so far. But what happens to our codes when an implantable device gets added to the mix?
Just take a quick mental break here for a second to reset your focus because this is where the coding gets highly specific.
Okay, Section 5, Devices with Ports and Pumps.
Here we're exploring scenarios where the physician takes an extra surgical step to create a subcutaneous pocket for a totally implanted device. When a centrally inserted catheter is placed, tunneled through the skin, and then connected to a subcutaneous port, like a portacath, we split the codes by that 5-year age mark again. For patients younger than 5, it's code 36560. For patients 5 years or older, you assign code 36561. Just remember the rule we established earlier. For these codes, the incision is fully closed with absolutely no part of the catheter remaining outside the skin.
Now, this next scenario introduces a really fascinating exception to the rules we've been building. When the central venous access device includes an implanted pump instead of a port, the age variable completely vanishes. There is literally no age differentiation for this specific procedure. Code 36563 is a single code that applies to all patients receiving a tunneled, centrally inserted device with a subcutaneous pump, totally regardless of how old they are.
All right, Section 6, Complex Access and 2 Catheters.
We've mastered the basics, so let's tackle a complex setup. A tunneled CVC requiring 2 catheters via 2 separate venous access sites, such as a Tessio-type catheter. If this setup is placed without a port or a pump, you'll use code 36565. If it includes subcutaneous ports, shift to code 36566. But I gotta give you a strong warning here. Your documentation must clearly and explicitly show that 2 separate tunnels were created. A simple dual-lumen catheter that just divides into 2 ends outside the body, that does not qualify. You absolutely must have 2 separate tunnels documented.
Next up, we need to spotlight a very unique standalone code, C9780. This is a Medicare HCPCS code specifically used for outpatient hospital billing under the Outpatient Prospective Payment System, or OPPS. It was created specifically to describe a brand new, highly specialized technique for dealing with stubborn occlusions. Let's break down exactly how this brilliant procedure works. It's called the inside-out access, or IOA technique, and it's specifically designed for the surfacer device to preserve access in chronically occluded veins. Step 1, the physician accesses the system via the femoral vein all the way down in the leg. Step 2, they push the device up and directly through a central venous occlusion. And Step 3, they navigate to an exit point in the right supraclavicular region. It literally works inside out to bypass the blockage. Pretty amazing, right? But, coder alert, make sure you catch this critical billing distinction. While hospitals will use that C9780 code we just discussed for their outpatient billing, the professional billing is entirely different. Physicians performing this procedure with a surfacer device will actually use an unlisted code. Knowing whether you're coding for the facility or the physician is absolutely paramount here. Before we wrap up, I want to briefly mention one final layer to your detective work. Always remember to check the operative report for imaging. Special guidance codes may be assigned when fluoroscopic and/or ultrasound guidance is used with most of the codes in this CVC series. Don't leave those guidance codes unbilled if the documentation supports them. So there we have it. You now know the exact anatomical targets, the critical variables to hunt for, and how to avoid that pesky port terminology trap. By treating every operative report as a puzzle to be solved, you can navigate these documents with total confidence and precision. But as new procedures like the inside-out technique continue to emerge, it begs a much bigger question. How will future medical innovations continue to outpace our current coding manuals? Something to think about. Keep learning, keep questioning, and I'll see you in the next explainer.